Hi, everyone. On today's podcast, we're going to talk with Paula Richards about advocacy work as a trauma-informed nurse educator.
Welcome to the Evidence-Based Birth Podcast. My name is Rebecca Decker, and I'm a nurse with my PhD and the founder of Evidence-Based Birth. Join me each week as we work together to get evidence-based information into the hands of families and professionals around the world. As a reminder, this information is not medical advice. See evbirth.com/disclaimer for more details.
Hi, everyone, and welcome to today's episode of the Evidence-Based Birth Podcast. My name is Rebecca Decker, pronouns she, her, and I will be your host for today's episode. We are so excited to welcome our guest, Paula Richards. If there are any specific content or trigger warnings, we will post them in the description or show notes that go along with this episode. But just a heads up, we will be talking about traumatic childbirth, and there may be some strong language and swear words in this episode. And now I'd like to introduce our honored guest. Paula Richards, pronouns she, her, is a human who has been answering, "What are you?" since 1993. She also happens to work as a perinatal nurse and nurse educator and likes to nerd out about OB-related nursing professional development on Instagram under the handle @NurseBrownGirl. Paula joined the Evidence-Based Birth Instructor Program in the spring of 2020, and she's also a guest teacher in the videos of our Evidence-Based Birth childbirth class when we talk about interventions during childbirth. We are so thrilled that Paula is here. Welcome to the Evidence-Based Birth Podcast.
Hello. I'm so excited.
So, Paula, can you tell us a little bit about how you became a nurse educator and what exactly, do you define a perinatal nurse educator? Like, what is your role?
Yes. I'm going to take it back even a little bit further. I became a nurse because of a series of life plot twists, probably up to 2 months before my high school graduation. I was going to straight up be a ballerina. I was admitted as dance major for Bachelor of Fine Arts. And I don't know if I repressed how I decided it would be cool to be a midwife, have never attended a birth, not knowing much about pregnancy. But in the quest to figure out, okay, how does that happen? How does that profession work? I learned that in the state of Ohio, at least at that time, and really still, mostly midwives in Ohio are nurses first. So certified nurse midwives are the midwife credential that's recognized in Ohio. We do have some certified professional midwives. I don't know if we have any CMs in Ohio practicing, but if they are, it's kind of underground. And so off to nursing school I went. And when I got to the awesome opportunity of becoming a labor nurse right out of school, what I noticed was that what I loved most about the work was laboring with people, seeing new families being born. And again, at least in the region where I work, that was primarily time that was managed or care that was, I'm not a huge fan of the word managed when it comes to labor, but it's time and clinical care that is, mostly overseen by nurses. So I fell in love with that work, and I found no reason to leave that if I loved it so much, if I found it so fulfilling. And when I was looking at advanced nursing careers beyond a bachelor's in nursing, I felt like the people most influential in my work were my mentors and educators, the people who really kind of lit a fire under my butt. And the people I had the most rewarding relationships with and the most growth with and the most opportunity for growth and change was through nursing education or educating other nurses, right? I use the term perinatal because it should encompass more than just labor, right? It's the pregnancy and the postpartum And for at least the first decade of my practice at bedside, I was at an LDRP. So it's like a one room birthing unit. A lot of them are like to be tagged with the name birth center, even though as you teach in your class, it's not really like a
It's
trade.
not a pre-birthing
Yeah,
center. It's not
it's not like a
mandated.
regulated
You can
title.
still have an epidural and a cesarean and all the
Absolutely. I
interventions
mean,
you want
it's a hospital. I mean, it was a hospital, right?
in the hospital,
Yeah,
right?
but there's
But
no
you labor and recover and have your postpartum stay all in the same room
correct. Yeah,
without.
there's no separate
What's the
postpartum.
lingo for that again? LD what?
LDRP. Yeah, labor, delivery,
LDR.
recovery, postpartum.
Okay.
So that's kind of like the lingo, right? And a lot of smaller hospitals are built in that fashion. It's a type of care model, inpatient care model that's actually not built for like thousands of births a year. So super high volumes. It's more of that, I hate to say this, but factory, right? Like move through, get funneled through the system of getting admitted, laboring, and we got to clear our board, right? We have to move that patient over to postpartum. So what I loved about that model, though, the LDRP, was that I was able to cross train to do both labor and postpartum, and you function as one unit. So it was something that I have noticed since that nurses who might do strictly labor or strictly postpartum kind of miss about the other side of that process, right? So on the postpartum side, what got us here, on the labor side, what are the consequences of some of the things that, we do?
It's like a
So,
missing link. Like,
yeah,
yeah,
absolutely.
you don't see the outcomes of the actions you took early, or
Yeah,
you don't understand what happens later on.
right. And the way that the US system's set up, it's even that really brief postpartum, right? So even that postpartum nurse only gets just the tiniest glimpse because we're not really working in a system where we follow those patients. They might come back for their next baby or their
But
next
you only
pregnancy.
see them for like a max of
Oh,
48 to
absolutely.
72 hours, unless they have major
And
complications.
beyond, right, for my own births, beyond my second postpartum day, I was like, I don't know what's happening, what's going on, what's normal, what's not.
Yeah, and I
Um,
remember like when I was in nursing school in my labor and delivery postpartum rotation, my nursing school was unique in that they required us to do a home visit in every rotation. So I had to find a labor and delivery postpartum patient who was willing for me to come like make a home visit
that's
and see
awesome.
them and their baby afterwards. And so I
Yeah.
went to their house a couple days after they were discharged and made a home visit and talked with them and gave them support and information and saw their baby. And it was just like, it was so cool. And I was like, it's just wild that is not part of the model of the United
Mhm.
States, that we don't like follow up after that 48 to 72 hours.
Yes, yes. I feel like I have grown as a clinician in that we get so hyped about the birth that even though recovery is super important, that those first couple of hours, I'm gonna keep it real. And I have absolutely okay. It's time to go. It's time to it's time to transfer, even if that means like moving on to the next patient. And I don't know what that says about like is it the need for constant adrenaline to keep me going through the shift? But I have learned over the last 15 years to really appreciate then seeing them postpartum truly, and that second day, even third if they stay. I think it was super eye-opening when 5 years in I wanted to expand my skill set a little bit. And within that same LDRP, cross trained to be a special care nursery nurse. So now I was seeing parents and families even longer term, right? Because those are kids who might need maybe a week of antibiotics, maybe a month or two of some other therapy, some late pretermers, preemies up to 32 weeks gestation, or I guess as low as 32 weeks gestation onward. And the dynamics and the amount of care that isn't just your patient, right? Just that baby, but it's truly that whole family unit in a way that really made me a better labor nurse. Like I can now, as a labor nurse, better explain what course in a nursery might look like, right? and hopefully in a way that isn't super threatening and scary, because I don't know how you can make a nursery not scary, but I try. I try real hard.
Did you go into nursing, labor and delivery nursing, before you had children of your own, or did they come later?
It was concurrent. So
Okay.
I was that girl, like senior year nursing school. Oh, and I was married, and we were talking about having a family and having, learned a little bit about reproductive health. Like, people don't just like sneeze and get pregnant. So, I'm finishing up. We might see a positive pregnancy test in a year or two, or, whatever. And I graduated nursing school in May, and I had my first baby in September of that year. So I had just finished my postpartum orientation. I think I had a shift, maybe two, on my own. And then I went into labor. And I was back 6 weeks later for labor orientation. And I was really young, and I actually I'm really grateful, believe it or not, for having kind of a shorter leave, because I was super isolated. I didn't have any other mom friends. And when you don't have anybody else to talk to, as much as you love a baby, you and a baby is a lot to handle without a reprieve or adult conversation. So, yeah.
So the other nurses were like your village or your community?
Yeah, they were. And there were a lot of us together too that were kind of growing our families at the same time. So then we ended up absolutely forming our village around each other.
Mm-hmm.
Yeah.
So what inspired you to become an EBB instructor a few years ago?
So I formally got into education actually as a parent educator. I ended up having 4 kids in 4 years, and I was working nights. And I primarily worked nights at bedside. But I needed more opportunities to flex my schedule. So I think one of the things that I love about nursing is that there's always the opportunity to find what we call per diem work, right? And so it's not necessarily like a set schedule of hours, but kind of when you can make work fit into your life. And the more skill sets you acquire, the more opportunities you have to make that kind of work for you, or at least work for my family. And what I noticed was that a lot of childbirth education starts with labor physiology that even labor nurses don't get. And I think a lot of nurses that I'm meeting through social media are even like, wait a minute, again, this blows my mind. And it's the ABCs of pregnancy and childbirth, right? But nurses are trained to get through orientation and staff a floor. And what that means is that you have to have a very discrete number of skills that you have to get checked off, right? And so we kind of get indoctrinated into what routine care is for that particular unit. And a lot of the physiology, even though we have a little background of it at school, is considered too specialized for something, for nursing school really to dive deeper into, or to make it, at least for me, a meaningful contribution to, my understanding of labor physiology. So that was super interesting. And I would come to the unit talking about the thing that I had just learned or read or, found through my prep of parent childbirth ed. And then we started seeing an increased interest in home birth, and not just home birth. So this would have been like 2011, 2012, because I feel like I
think that's right after the Business of Being Born kind of came out.
Yeah, okay, so that story checks out. I had been teaching for a little bit before I found your blog. So I've been kind of stalking you for a while.
Join the club.
Oh, okay. That's great. I love that. Yeah. And so I had, parents asking really good questions about, what was necessary and what wasn't. And just, a new generation of patient, right, who like genuinely wants to be involved in the decision making. And it was embarrassing the amount of questions that my immediate answer to was like, well, I don't know, like it's kind of like what we do, right? But I'm nothing if not tenacious about trying to find that answer for you if I don't know it. So I found your work, and I think even before signature articles and stuff, I was like, okay, so you want to go to evidencebasedbirth.com and Dr. Decker breaks this stuff down, and we can come back next class and you can talk about it, or you can talk about it with your provider. So that it feels like it's been a long time coming, and I ramble, so I don't even know what the original question was. But I've been
Oh yeah, we're talking about becoming an instructor, but I'm curious. So for a lot of labor and delivery nurses who become EVP instructors, they talk about how there was this moment or time point when they realized that a lot of what they've been doing, that they've been taught as nurses, was either not helpful or even harmful for families. Like, did you have a moment like that, or did you realize that the evidence on something did not back up what nurses happen to be doing?
I mean, every new thing I read from you, even if I go in, I'm maybe 80% familiar with the content, and then I'll read something that totally blows my mind. So when I first reviewed the active third stage management, the Pitocin for third stage,
after your baby is born.
Yes. So I had been peeping some nurse threads, and I don't even remember where, but they were talking about, like, somebody even called it pedantic difference between fundal assessment and fundal massage. And when I read about fundal massage, like truly being an intervention, right? But something that I think every labor nurse that I know, and probably every postpartum nurse that I know, so I'm speaking from my own personal experience, right? Truly conflates those two things, right? Oh, well, but we have
to. Can you explain the difference for our listeners who don't know what fundal assessment and fundal massage means?
And the conversation goes something like this, oh, well, we check a fundus, which is the firm part of the uterus towards the top, which kind of lands at around the area of the belly button right after birth, right? We assess that, and usually for the first 2 hours, every 15 minutes or so, and then every couple of hours after that, or whatever, right? That's great. And we're assessing for primarily what we call tone, so how hard or kind of mushy, and the technical term is boggy, it is, which helps us also then gauge how well it's potentially controlling bleeding, because you have a muscle that's kind of clamping down on that dinner plate sized wound that was created when the placenta detached. And
you want it to be kind of firm.
Yeah, because you want it to be kind of clamped down, right? And you can do that. And actually, you as in the birthing person, right? Like the person owning that fundus can do that. And I now teach my patients what it is that I'm feeling for, simply by pressing gently at about the level of the belly button until you feel, I call it a knot or a ball, but that's essentially what a firm fundus will feel like, right? But fundal, and that would be a fundal assessment, right? Assessing,
You're just checking it.
Exactly. Mm-hmm. Determining the status of the uterus after birth, right? But we teach fundal assessment by way of essentially mashing down on the abdomen, right? And that is technically fundal massage, right? You're massaging the fundus and
rubbing it kind of roughly or hard.
That's why I call it mashing, right? It's like the technical term again is a fundal massage, but nobody's ever had a massage like that and, felt good. That, which makes total sense. But why are we mashing on people every 15 minutes for the 2 hours of a recovery? It doesn't feel good. I have to go through that several times. Mm-hmm. Yeah. It's super uncomfortable if, the bleeding looks okay, right? We're getting a visual assessment of output, and then, you can feel whether it's hard or soft. We know that if somebody is sitting or laying in one position for too long and they go to change positions, all of the blood that's kind of pooled in the vagina comes out at once. And I mean, we even teach it in discharge instructions. Like you might see clots, up to the size of a lemon or an egg, and that's considered normal, but never kind of put it all together, right? It's like, yeah, dude, massage equals intervention, assessment, totally different part of the nursing process. What are you doing? So that's probably the most recent example, because I feel like that's one of the more recent articles where I've had a moment of what the fuckery is happening.
Yeah, and this is something, if you go to evidencebasebirth.com/third stage, spelling out the word third, and you search for the section on are there benefits to uterine massage in the third stage of labor, talk about how there's very little research on the subject, but the largest study we found on the topic found no benefits to uterine massage when a patient is also given synthetic or artificial oxytocin or pitocin after the birth to help prevent postpartum hemorrhage. And lots of people have contacted us at Evidence-Based Birth to say that this experience may be painful, uncomfortable, or traumatic, and it was done without their consent. It's like the nurse is like, "Oh, I'm just going to check your fundus or your uterus."
Not even.
But then they go in there and like really properly massage it. Yeah. What do you say?
Let me check your belly, right? And then the next thing you know,
they're like mashing into your stomach.
True.
Where you just
okay, so I say this on my Instagram. I'm a forever trigger warning, content warning account.
Yeah.
Because my everyday is like, oh, and then this other fucked up thing happened, and time to go to breakfast, and people are like, wait a minute, what did you just say? And so I want to say that up front. I can tell you that, especially after C-sections, so when people are pretty heavily anesthetized, I have definitely performed massage deeply enough to feel the spine through the abdominal wall. Like you are really...
Even after someone just had a cesarean incision?
Yeah. Mm-hmm. Yeah.
Where you can actually stick your hand so deep into their abdomen
and then down. Yeah, and it's almost like a kind of a scooping motion that happens because you're trying to, again, express clots. And the conventional wisdom is, that stuff can build and build and build. And one fun fact about the uterus is that at term it can hold up to 6 liters. So, it's an organ that's been stretched out, whatever. But we typically, after we are wrapping up a case and before we head to the recovery room, we'll do massage to express, and that is included in the estimation of blood loss, and then we head on over to recovery.
So you try to like massage out blood from the uterus.
Yeah, exactly. But like forcefully, right? It's not gentle, and I have to think about what does that mean, because there might not seem to be any consequence right then, but that patient takes their body with them and everything that's done to them through their recovery period, right? And then if we keep repeating that kind of vigorous mashing through the duration of a 2-hour recovery, so every 15 minutes for 2 hours, depending on where you're working, right? Or what, again, is the conventional assessment, that super sucks to think about.
So what do nurses say when you educated them and you talk about how actually there's no research to support us doing this?
Jaws on the floor. Yeah, it's a collective like, so my life is a lie. And not only that, like with most other things that don't really help, it's the immediate desire to justify how they have seen it help before.
So there's a defensiveness.
Yeah, absolutely.
Yeah.
Mm-hmm. Because
then it makes sense because they're protecting their, moral integrity. It's like,
yeah, absolutely. Like, how can I come back and continue to do this if I'm, injuring,
Especially if you go into nursing to be a healer. Like, nursing is essentially one of the healing professions. And to find out that you were trained to do things that may harm people and not help them, I can see how you would justify it and be like, well, I saw it help this one time.
Absolutely, yeah.
Or all my patients that I do it to don't have it. And the ones that I don't massage, they do have, a hemorrhage, which, as we know, that kind of thinking is very flawed because our memories are not perfect. Yeah. That's not a research study.
And I mean, that happened with, for example, like IV access, right? So I talk about IV access and IV fluids when I teach fetal monitoring, which I do for the Association of Women's Health Obstetric and Neonatal Nurses, A1. And we talk about what are considered intrauterine resuscitation methods, but it gets into the heart of a lot of routine obstetric care, right? Which is kind of like revolves around fetal monitoring and, et cetera. And that whole class is a lot of what the fucks, like in succession, like, excuse me. And so when it's led to some really good discussions about like, but time out, knowing now what you do, let's think about how that changes your approach to what might be typed as a difficult patient because they come in not necessarily, wanting to buy everything we're selling, right? When a lot of nurses pride themselves on things like their efficiency, right? Like, I am skilled because I can throw an IV in anybody and I can do it quickly and, whatever, right? I can keep the ball rolling. We get a lot of praise from each other when we might not otherwise, and from just like the system we work for at large. So anybody who comes
There's a lot of kind of reward from the group. And social reward and social affiliation when you're efficient and things are done urgently and quickly and
absolutely time. Mm-hmm. When you have somebody come in who has a lot of questions, it kind of puts a wrench in those in just your whole process, right? And so somebody who's first learning, which is kind of what I find fascinating about nursing education, is that I'm just full of problematic generalizations, but I feel like in my experience, again, we're not really good educators. We're not really taught what it is to teach, right? We're just expecting that somebody who has been deemed proficient or an expert is now also expert at, methodology of like pedagogy or whatever, right? Or essentially the discipline of teaching others. And expert nurses, expert anybody, because I feel like I saw some of this in my undergrad, even with like some science poor graduate TAs who had to teach, like organic chemistry. When you reach a certain level of knowledge, breaking that down into the ABCs really takes some work, right? It really takes some reflection. It takes some dissection of your process as to how you got there. And so I've seen a lot frustration on the part of not just educators, but preceptors, because preceptors, which are nurses who train other nurses on the floor, are chosen a lot of times because they're efficient, right? They're highly productive. They are the kind of nurses that the unit wants more of, right? And the pace might be a little chop, which is not conducive to learning how the body works through birth, right? That's all stuff that has to happen, that people have to put in time on their own. As much as we say and claim, like, oh yeah, it's super specialized and you get some on-the-job training, the bulk of it is, again, about how do you function as a cog in the system, right? Can you contribute to our productivity? And so if you find yourself in an institution or a unit where, culturally, like nothing has changed for 20 years, right? And then all of a sudden because you have done your own homework, and we're seeing a lot of nurses who are like, I want to work in birth, right? I am a birth worker, and the next step along my path to whatever is to be a labor nurse, right? And they themselves become traumatized by
I was gonna say they get beat up in a way, like
what it
emotionally.
takes, absolutely, because they officially know more about the physiology of birth than, Miss been a nurse 20 years, because she knows how birth
She knows
works at
managed
that
birth.
institution. Yeah, exactly.
Right.
And so there is an element to training that, if you don't have a good preceptor match, can break that first job, There's an element of training that involves, like, unfortunately, how to become a nurse, which is a lot about those kind of harder skills, right? So I, for example, have noticed that I'm more comfortable than newer nurse, not just because I feel really strongly that if somebody doesn't want an IV, I'm not touching them, right? Like, that's super invasive. It's battery if I touch them without their consent. And we can talk about, what their concerns might be about having IV access, or the need for IV access. But when in an emergency, I'm confident in getting that IV, right? Where somebody who's still maybe practicing might say, okay, well, in the midst of an emergency, I don't know that I can get that IV. And that's not going to come without some time and practice, right? And so then it's navigating those conversations. And then the reflection that, like, yeah, dude, that takes some time.
Yeah, this is feeling heavy for me, just coming from a background of being a nursing professor. Like,
I'm sorry.
No, it's good. It's just, I've been having all these deep thoughts recently about how nursing education as a whole just needs to be completely reformed
Yeah,
and
burn it all down.
undone and then rebuilt from the ground up. But
Yeah.
there will always be so much resistance, because of white supremacy culture and resistance to change. And some of the things you're talking about, like a sense of urgency, if you Google white supremacy culture, there is a document by Tima Okun that lists the different aspects of cultures and institutions that are built on, like colonized workspaces and white supremacy culture. And one of them is a sense of urgency.
Yeah.
And I've thought a lot about how present that is in labor and delivery units and hospitals, that sense of urgency, like we must speed this birth up, we must get this done, we must get this patient out of here. And we were at the instructor retreat a few weeks ago, and all of a sudden I realized that failure to progress, because we're working on updating that article, the research
I
on
can't
that.
wait. I can't wait.
Oh yeah, so failure to progress, that whole diagnosis that your body is failing to progress in a timely manner, in our subjective point of view,
Mm-hmm.
is based on that a false sense of urgency. And you called it efficiency. And why are we putting ourselves in these situations where we have to rush? Because we don't value the actual lives of the people who work there and the patients we're taking care of. Like, if we're rushing, but nobody actually really cares about the nurses. Nobody actually really cares patients except for maybe the nurses. And so you've got these, oppressed groups that are trying their best and it really
Oh my gosh.
failed them.
Talk about blowing my mind. When I first became a professional member, when I did what I consider like your flagship, evidence-based care modular course. And, you started talking about, it has a background in sociology, but those pillars of oppression and just like systems of oppression, and what kind of like upholds what I do, what I do
What
for
keeps
work.
that in place?
Yeah, exactly. Like, how that plays out in lateral violence, because if, you're so disenfranchised that you don't see a way forward or upward, right, for more systemic change, then like, what are you going to do? You're going to nitpick the new girl, right? Or whomever. Yeah, that's the stuff that absolutely feels too big. But I continue to do this work, and I continue to strongly ground myself in continued bedside, because I try to be like a full-time educator and I failed at that. Like, I missed patient care, but I missed the connection and probably the immediate satisfaction that comes from role modeling that change I want to see, right? So when I graduated from my first big girl job, where I was at for almost a decade, my second nursing job, and I had, been very familiar with your work up to that point. I feel like I was a professional member at that point as well. I read all the things. I knew in a theoretical sense how cultural obstetric, like routine obstetric care is, but I didn't live that, right? Like, I was very proficient and comfortable in the unit where I learned to be a labor nurse. But that second job, for I think most nurses, blows you out of the water, right? Because when you get comfortable, you know kind of what to expect. And then you meet a new provider, for example, who likes to put forceps on at every birth for what feels like no reason. And if you've only ever worked at that institution, that's kind of like how babies come out, right?
You
Having
just kind of accept the things that are every day and don't question them as easily until you go to
abs-
another job and you realize that people
absolutely.
are doing things differently.
I worked at an institution where they have not had midwives. I'm calling them delivering privileges because that's what they're called, but it's like permission to attend births, right?
There's
Um,
no midwives with permission to attend births.
Correct. Yeah. So they will see patients through their prenatal care, but essentially medical residents, obstetric residents handle all of the birthing.
And is this like normal for the nurses there? Like they don't really question it?
I mean, that kind of the thing though. I was openly what the fuck eyes to everybody, right? And under their breaths are like, yeah, dude, you just wait to call him until you see the ears, right? There's a lot of protective manipulation that gets learned because they might not feel empowered or like that they have the agency to openly report or, like raise questions. But I'm so tired of that shit. Like, I can't, no, right? I love what I do and I can't continue. And I could see myself doing it for another 15 years, but I cannot with that level of moral injury, right? And so,
Once your eyes are open, you can't like close them shut.
yeah. And I mean, and it's been by degrees. I mean, I was that nurse for a long time, was like, I don't care what you put in your mouth when I'm not here, right? And there's the like subversion of, like, no, there's really no benefit to fasting in labor, but I'm not going to openly say or, talk to the person who helps draft the policy that, like, hey, can we get this changed? That seems too hard, right? But in the moment, I can make the labor experience better for that particular person because as their nurse, I can make that choice, right? I can choose to say, like, oh, the policy says, or, like, well, we can't let you, eat anything or ice chips only, whatever. I still hear that shit every day. And now I'm just like, I mean, listen, we're going to say that, and you're going to get somebody after me that might say these words, but you can put whatever you want in your mouth and you can tell people that the nurse Paula said that I could. And so what, right?
It takes a level of like confidence
I
though.
just feel like,
Hearing,
yeah, well, and P.S., some of that is a privilege from having several per diem jobs, right? Like,
okay.
let me see how mouthy I can be because I feel like in general, my patients have good outcomes and I work well with the team, but I can't continue to obfuscate, like, it's just the facts are oh, you're hungry? Okay, what can I get you, right? Like, I don't know what else to tell you. That conversation is helped, though, by approaching every encounter by rightfully assuming that the power's with the patient, right? And sometimes I love admitting people, I love being the first nurse they meet because I can be that
Make
person
sure
that
they know
sets the
that
tone.
they have the power.
Absolutely, right? Like, for example, when I do triage, if I get the chance to, I take the gowns out of my rooms. And I learned that from you. I think it was from your series on like vag exams and stripping membranes and stuff. And I think one of the questions was like, what if I just don't want to? And I think you were just so casual and like, so like keep your pants on. And so many triage visits. Well, firstly, let's back up. Nobody needs to meet me in a gown with no underwear, right? Like for the first time. Talk about an immediate power imbalance. It's so vulnerable. But if what we call the chief complaint, so like the reason why you're presenting for care, is, a headache where we might be checking your blood pressures, I don't need to know anything about what's behind your underwear to check your blood pressures, right? Like we can easily lift up a shirt or top or whatever to do fetal monitoring if we absolutely have to, right? And just like in an office, if the assessment or the complaint require shoot
Warrants
Paula.
or
But yeah, like
yeah.
if it warrants some kind of pelvic exam and that is consented to, right? Then, like, well, that, it's like, here's a sheet and we'll give you a few minutes and come back and do the thing or not, right? Like you can also say like, actually, no, I'm going to keep my pants on just like you did in that video. And that's not stuff like, how do you write that in a policy, right? Like the triage policy states like,
Ask them if they want to keep their pants on so that they don't have an unnecessary
how
vaginal
ridiculous
exam.
how ridiculous is that, right? And so maybe I'm just not a patient bitch. And I just found that I didn't have the time to play games in offices with people who aren't new to women's health, but are so entrenched in women's health that all of this has to be taught to them, right? That like
This is why you're doing several different per diem jobs so that you can have like the freedom and independence to
to tell
truly.
everybody to fuck off. Yeah, because I'm like, okay,
Yeah.
well, let's see how far I can push this, and then if you guys don't appreciate me, let me go find something else to do. Yeah, yeah,
Because I know a lot of nurses who are afraid to speak their mind or to tell their patients the truth sometimes because they know they could lose their job and they're depending on benefits or whatever.
yeah. I mean, again, it helps to have evidence-based birth as a reference
Mm-hmm.
because it's a little bit of come at me, bro, right? Like, oh, you need to see the evidence on that, or like, oh, what research did I find that in? BRB. I don't have to. I mean, I'm gonna flex a little bit. I could if I wanted to, but it's kind of nice to have a repository of like specifically we know this might be a problematic practice and that if somebody questions like the why or why not or like the why I would say that's an okay thing to do between your work and the work that Kristen Pascucci's done at Birth Monopoly, that's really helped me fine tune my scripts for patients, right? And not just for
I
patients.
see Kristen's poster behind you. Poster about obstetric violence,
It is the
right?
obstetric violence culture pyramid. Mhm.
Mm-hmm.
Yeah,
Yeah, which you can find at Birth Monopoly's shop.
yeah. So it's just so important to the care that I give. Not only the patient education, but then to turn around and because I infiltrated the culture. I mean, it feels so much it like it's such a part of me, but at the same time, because in the back of my mind, it's like a fuck you to everybody. It feels a little bit like infiltrating. I can then casually say, or my colleagues now know to ask, like, oh, well, what do you think about that? And, That's what I mean by nerding out. Like, oh, well, in this article I just saw, blah, blah, like this is, why we should get over ourselves when people say that they don't want IVs. Like, okay, well, we can get to the bottom of that, but also don't touch people without permission, right? Like that's just a very clear cut like thing that we just shouldn't do. Yeah. And it blows people's minds every time.
When you say that it's just as simple as that, we don't touch people without their permission.
Yeah.
Because that's not taught in nursing school.
Oh my gosh. We were talking about, I now share some researchy things on my Instagram stories. And I haven't been doing it for more than a few months, so I can't even say like one of the most recent ones. I don't even know. I save some of them to highlights. Again, it's a lot. I feel to me, it's a lot of talking shit. And then nurses in my DMs are like, what? We were talking about titrating Pitocin for induction or augmentation. And somebody said, they asked their nurse to turn it off and they didn't. And the way that oxytocin or Pitocin works is such that once you get into active labor, it should be like a positive feedback system in which it's self-sustaining, and we should work at, decreasing the rate or turning it off entirely. And of course, people were like,
and the guidelines say
no.
During an induction with Pitocin, once you reach active labor, it should be turned off.
Right.
And the professional guidelines say
and this. Absolutely. And I pulled out, I was like, as an A1 instructor, guess what? Like, this is, like in curriculum, it's in the text. Yeah. Everybody got mad. Like, they were immediately like, yeah, so that's a no, unless I want to, for real, get in trouble, right? And then,
so if the patient asks to turn it off, which they have the right to do, and it's actually evidence-based, there's clinical trials showing this, the nurse in that scenario just said, no, I'm not turning it off. And
correct. And so it was
yeah, exactly.
It was twofold. It was, and I think that patient story came from somebody who then became a nurse and was like mad as well, right? Like, oh my gosh, this makes me even more mad about this thing that happened to me because I asked my nurse to turn it off, and she wasn't a labor nurse at that time, I don't think, and they didn't, and that was kind of traumatic. And then I had somebody else who was initially not a labor nurse. She came from some other specialty. And her moment of, wow, okay, was like straight up saying, you mean Pitocin is just like any other drug that patients can refuse or decline or whatever, right? And in the same message, saying like, any other patient I've ever taken care of was, like could tell me to take my meds, and stick them somewhere else. And it's a non-issue, right? It seems to be, or at least in her previous experience. And she was like, I can't believe that even having that experience, right? The dominant culture of inpatient obstetrics is such that no, what we do here is we turn the pit on and we run it like so, and then you keep increasing it until a baby falls out or whatever, right? Yeah. That was an interesting week in the stories for sure. Yeah.
So thank you for sharing some of those concrete examples of like the gap between evidence and human rights and then actual practice. Do you have any, like, as we wrap up, any words of advice for any nurses in particular who are listening, who are maybe feeling discouraged or downtrodden or defeated about their jobs and the difficulty they find themselves in?
Get a therapist. Have somebody to to talk to. And that is not, I mean, like, even for me until really recently, not something that felt doable. I had a really good group of nursing colleagues, like, so peer colleagues, that actually two of my closest ones no longer do inpatient OB work. They're still nurses. But on some of my toughest shifts, I can call and very quickly express my feelings without having to give like the backstory or, like, and this is why that was fucked up, right? They kind of understand the common language of the things that we see every day and how they can get heavy. So, peer support, I'm going to go back to how much of obstetric practice is cultural, though. And I mean, my first two jobs were hospitals 20 minutes apart from each other. And I was like, what year is this?
You're like stepping onto a different planet.
Yeah, absolutely. And some of that, again, is composed of what the providers do, and some of it has to do with nursing administration and just kind of like what the kinds of qualities of nursing and nurses that are prioritized in that unit. Sometimes it has to do with the, I don't know, like common interests outside of work, right? Like it's a really kind of rough work to do when you don't have at least like what we call a work wife, like just somebody that will have your back, or that you can at least again have that peer support from. And if you're having a hard time, especially because I am rooting so hard for a few doulas who are kind of getting through nursing school on their journey, something that I tell them is like, if you get in there and it feels insurmountable, that honestly says more about the environment than it does about you, right? You have power, you have knowledge, you have a lot of influence with patients. And that's something that I'll be forever grateful to Kristen in learning how to speak about, like just turning the conversation around and like to who is in charge here, right? And when I have done that, I feel like I get some of the best results, because ultimately everybody on the team will say that they do want what's best for that patient and family, right? And so it's kind of like when you do those quick check-ins, like, okay, and PS, let me amplify what the birthing family wants here for the rest of the team. Those kinds of messages tend to work really, really well.
Mm-hmm. So I know that our listeners can follow you at Nurse Brown Girl with the trigger warning. But
Yeah.
you do a lot of amazing free teaching there, especially if people engage with, your stories. Do you have any projects you're working on that you would like us to know about?
I haphazardly teach the evidence-based birth comfort measures for labor nurses workshop with some colleagues in this area, and that's virtual. So that's been super fun. Again, I feel like I love your work so much. But it was just amazing right off the gates of the pandemic to have that resource be available. Currently looking at workshop dates in November. I kind of slowed down this year through all of my jobs transitioning. I can also now virtually teach the advanced fetal monitoring course. So I'm doing that with an awesome teaching partner, Jen Atkinson, whose background's in as a legal nurse or expert. So I'm learning a lot from her in that collaboration. And I am working with Mandy Irby of The Birth Nurse and Maggie Runyon of Your Birth Partners podcast on a trauma-informed birth nurse program. So that has beta group that we're hoping to launch. We are launching October 20th. So that's super exciting. And so that stuff, I have a link tree in my bio on Instagram. That's probably the best. I haven't gotten my life together enough to be like a business. So,
You've just got your hands in all different
I'm just kind of hanging out. Yeah, I'm just kind of hanging out.
Yeah.
People are
And
just hitting me up like, "Hey, do you want to do this thing?" I'm like, yeah, okay. I am terrified, but shoot, what do you need me to do? So
yeah.
we'll see. We'll
Well,
see how
our
it goes.
listeners are listening to this in November, so hopefully your Trauma Informed Nurse project is launched. And also, you may have workshops coming up in the next few weeks people can sign up for. Just go to evidencebasebirth.com/events, and you can look for a virtual event in the Cincinnati area. We have a really great group of instructors there. I'm really proud of how you all have come together and are collaborating and making change, making waves in Cincinnati and the northern Kentucky and southern Ohio area. So we're super proud of you, Paula. Thank you so much for coming on the podcast and
Thanks for
sharing your stories with us. Thank you.
Today's podcast episode was brought to you by the online workshops for birth professionals taught by evidence-based birth instructors. We have an amazing group of EBB instructors from around the world who can provide you with live, interactive, continuing education workshops that are fully online. We designed Savvy Birth Pro workshops to help birth professionals who are feeling stressed by the limitations of the healthcare system. Our instructors also teach the popular Comfort Measures for Birth Professionals and Labor and Delivery Nurses workshop. If you are a nurse or birth professional who wants instruction in massage, upright birthing positions, acupressure for pain relief, and more, you will love the Comfort Measures workshop. Visit evbirth.com/events to find a list of upcoming online workshops.